We'll move on to our next speaker. Our next speaker is Dr. Prithvi Chandrakanth. He's an innovator known to all of us, and he's currently working as a vitreoretinal surgeon at Chandrakanth Eye Hospital, Calicut. He'll be speaking on the topic a deep dive into nucleus drop.
Good morning, everybody. Thank you, Dr. Ambika, for having me here, giving me this opportunity. I'll be talking on a deep dive into the nucleus drop. So basically, it actually starts from our OPD itself. So finding these risk factors pre-operatively will help us a lot in our OPD itself to get a clear picture of whether you're going to have a nucleus drop or not. So the first things which would be is weak zonules. So where can we expect these kind of weak zonules? One is in a case of pseudoexfoliation, another mature, mature cataracts, and then any history of previous trauma would actually give you an idea on that. And then any visible zonal weaknesses or absence pre-operatively can be assessed. High myopia cases should be actually be seen a little more carefully. Previous ocular surgeries, if any, should be taken into account. The other risk factors is posterior capsular tear related. Those can happen in small people, in dense cataract, posterior polar cataracts. Also, getting a previous history of any intravitreal injections would be really insightful, because there could be some kind of lens touch while injecting. So that has to be ruled out as well. And then less experienced surgeons are more likely to cause PCR, so that has to be taken care of. And patients, if they are very mobile, it becomes a little difficult. What about those risk factors intraoperatively? Those are tears in posterior capsule during hydrodissection, radial progression of any anterior capsular tears, equatorial or posterior rupture of capsules, and PC rupture by instrument, and any ZD more than 3 clock hours should be a small warning sign for us to actually expect nucleus drops. And what are the complications of a dropped nucleus? This is elevated intraocular pressure, intraocular inflammation, corneal edema, cystoid macular edema, and retinal tears and detachment. So in this, few of those are actually very important for a vitreoretinal surgeon, because if cornea becomes edematous, then it becomes very difficult for us to even remove the chunks from the vitreous while doing the surgery. And we'll come to that. So the next thing is prepare an action plan. So we need to know that when we have such cases, we should actually have a action plan even before we start the surgery. So conducting some practice drills with a few of the OT assistants and getting them trained during this kind of situation would be ideal. So you can actually train the OT assistants on what machines are there, how to operate it well beforehand, and also be sure that these OT staffs are present during the particular surgery when you're taking it up. So smart scheduling is a way to go. So try not to keep these kind of complicated cases which can result in nucleus drop in the early morning, early OTs. Rather keep it at the end list, and also make sure that those trained OT assistants are there for you, because already you'll be in a different state, and you need to be calm, and you need OT assistants who can help you with all the instrumentation and the anterior vitrectomy, etc. And also posting these kind of cases on the day when a retina surgeon is there in your institute would be a better option, or at least you know somebody who is there for you. It becomes more easier for you to handle this kind of cases. Preparing an action plan, again, anterior vitrectomy. So we should be very sure that you have a OT assistant who knows to get these instruments right exactly when these kind of things happen. So get them primed in anterior vitrectomy cutters, keep corneal sutures ready, any appropriate backup 3APs IOLs for circle placement, and triamcinolone. So these are the few things which we need to keep it ready, and they keep it ready, and it becomes easier for you to actually manage the case. IOL, so I would always suggest any IOL which is a three-piece IOL. So if it by chance it even drops down, so we can actually we don't really have to make any incision, just three ports, and we can go in and fix the same IOL into the sclera. So that becomes very easy for us also. And patient education, so once you know that these kind of cases in the OPD, it's always better to ask them and counsel them that that could be a complication, and it would be actually helpful for you because they are expecting that could be an problem. And it becomes easy for you post operatively to explain to them, and also explain to them that there might be a second surgery involving a fixation of the IOL. The second point which we want to say is don't chase the nucleus. So many times what happens is they first of all recognizing the complication, sudden deepening of AC, sudden transitory appearance of red reflex, difficulty in holding nuclear fragment with the phaco tip, descent of nucleus away from the phaco tip, and pupillary snap signs. So these are the signs which we actually have to see, be very attentive while doing surgery, so that you know that there is something like this happening when and you can expect a nucleus drop. And then any retained nucleus which is small and there's no vitreous prolapse, no disturbance, with adequate capsule support, you can actually continue phaco carefully and try to finish it. The primary objective is retrieving of all the retained nuclear fragments without aspirating the vitreous, because once you catch hold of the vitreous, then there is a vitreoretinal traction happening, and it can actually cause a retinal detachment or retinal holes, and you might not even know that. And then retained fragments can be brought into the AC. So with the OVD, you can slowly inject the OVD in such a manner that there is no vitreous disturbance, and try to get it into the AC. So then you can actually take it out. Or maybe even slowly with the lesser infusion, you can even use a phaco, but very carefully. And bottle height should be lowered and the vacuum should be reduced. Otherwise, you'll be catching the vitreous again and causing retinal holes. Avoid sculpting and rotating the nucleus again, because you might actually stand vitreous and you might give a traction over there. And avoid using aspiration exactly for the same thing, not to catch the vitreous. Maintaining infusion. One more thing is what if there's vitreous, it was always better to inject with the visco and put the vitreous back to its place if it's not disturbed much. If it is, then we'll have to use an antivitrectomy and go at least till the posterior capsule and cut all these vitreous. Yes, so this is one of the main point which I would want to stress, because it is always a temptation for us to go and chase the nucleus, because it becomes like it's falling, we need to go and chase it. But at that particular point, what happens is a lot of people disturb the vitreous and there will be retinal holes. And also I've seen cases where they've gone with the instrument and actually touched the retina and caused tears. So what happens is these patients come back to us with retinal detachment, which is very difficult to manage because it's a very huge tear. So few cases go up to the macula also, because they go and scoop it out. So that has to be very, so if it's going, let it go, it's not a problem, because we can manage it much better later on. Do not continue with the phaco in presence of vitreous, and because the phaco probe has the aspiration, it doesn't cut the vitreous, it just aspirates and tries to pulls it. So what we do is we need an antivitrectomy which can actually cut the vitreous. So having maximum cutting rate available on your machine, that you should use that vitrectomy, and then with low vacuum and low infusion pressure. Another thing is you can also use intracameral triamcinolone to find out if there is vitreous in the anterior chamber, and try to use a anterior cutter. Suturing the wound would be very helpful for us. It would be really good if it's interrupted. If not, you can even do a cross suturing, and also the side ports and the main ports both should be sutured well. Yeah, IOL of choice is 3-piece, because we can always use that to do the SFIL later. Post-operatively, we need good corneal clearance if you want to do a retinal surgery. So then maintaining the pressure and getting a good corneal clearance should be easy for the surgery. Just video showing the one 3-piece IOL drop which happened. and making small scleral incisions here, maintaining the glow pressure with the infusion, making scleral pockets here, one on either side. So once the scleral pocket is done, scleral incision is small ports are made for the haptics to come out, and residual vitrectomy is done. Core vitrectomy is done, and you can see there is a 3-piece IOL which has fallen down, and then removal of all the vitreous besides the IOL, and then slowly what we do is try to catch with the max grip forceps, bring it up, and slowly with the max grip forceps holding the tip of the haptic, we bring it out. So this can be done meticulously, and that's about it, because we don't really have to make a big incision. We just need 2-3 ports, and this haptic is put in the tunnel, the scleral pockets, and suturing is done, absorbable sutures. So that is it. So that becomes so easy for us if yeah, suturing can be done, and then that's it. Yeah, thank you.
Thank you, Dr. Prithvi, for giving a vitreous retinal surgeon's perspective on nucleus and IOL